412 patients conclude by bowel abnormality and cholestasis were common finding on abdominal imaging of inpatient with COVID-19, and the patient who went to laboratory often had ischemia, possibly due to small vessels thrombosis. In this study, they found about 34% of patients presented with GI symptoms at the administration, and 33% of these patients had abdominal imaging. And found about 31% of the patient showed abnormality in the bowel wall in the CT scan, and most of them, about 50%, were in ICU patient. And 54% of the patient showed finding of distended gallbladder and cholestasis on the ultrasound, and again, most of them were in ICU patient and critically severe ill patients. Now we'll get focus and about the several abdominal part which are target for the COVID virus. We'll start with the bowel, the first target for the COVID. The common manifestation of the bowel in the COVID patient is thickening and ulcer enhancement and finding of ischemia, such as nematosis and portal venous gas. But nematosis and portal venous gas, as we know, can see commonly in critically ill patient as well, with other etiologies such as viral enteritis or a patient in positive pressure ventilation. Other manifestation also we can find it in the abdominal imaging, the distended fluid-filled bowel that reflecting the diarrhea due to a change and alter in the gut-lung axis of the normal flora that affected by the coronavirus. And we can also see the late complication of the ischemia with bowel perforation. The possible explanation for this spectrum of the abnormality could be due to direct viral infection, due to high affinity to angiotensin-converted enzyme receptor, or could be contributed to the small vessel thrombi or non-occlusive mesenteric ischemia that caused by the severe infection, as mentioned before. This is an example of 57-year-old man with high clinical suspicious for bowel ischemia. This is a positive COVID patient, and we can see non-specific finding of diffuse mucosal wall thickening of the small bowel with mesenteric congestion as well as small ascites. Still, this is non-specific but highly suggestive for early ischemia or could be due to infection. Another patient, 47-year-old man with abdominal tenderness. The CT scan of the abdomen showed the typical finding of the bowel ischemia and infarction with nematosis intestinalis, decreased wall enhancement, and wall discontinuity with free fluid, which is confirmed in the laboratory. Can see the abnormal bed-looking bowel segment, and they found this abnormality has sharp margin and does not respect the watershed vascular distribution, which confirm and supporting the theory of small vessels involvement rather than a big vessels or occlusive ischemic effect. This is another patient, 52-year-old man. They found a portal venous gas in the radiograph, suggestive for bowel infarction. CT scan done after laparotomy and confirmed the presence of the gas within the portal vein. And we can see this is the histological pictures of the resected bowel that shows fibrin thrombi within the submucosal arteriole, that confirming that the disease affecting the small vessels and causing main explanation to cause this abnormality. Again, we have another 34-year-old man with elevated liver enzyme. Ultrasound was performed and show multiple linear echogenic foci with dirty shadow that suggestive for air, and confirmed in the CT scan of portal vein gas as well as the ischemic vascular vein. This is again a 51-year-old man in ICU and intubated patient that show diffuse gastric wall thickening with nematosis intestinalis, as well as portal vein thrombosis and portal vein gas. The endoscope of the upper GI showed the gastric mucosal ischemia. Now let's move to another target for the COVID, which is hepatobiliary system. And cholestasis is the most common finding seen in the ultrasound performed for these critically ill patients, reaching up to 50% in most of the studies. Other non-specific findings we can found in the ultrasound: gallbladder wall thickening, hepatic steatosis, features of hepatitis, and portal vein gas. About 50% of the COVID patient may present with liver dysfunction, evident by elevated liver enzymes. And liver dysfunction in the COVID patient likely due to viral effect on the hepatocyte that causing severe inflammation and disturb of the immune cytokine storm that leading to inflammation and damage of the hepatocyte. Another suggested that the hepatic involvement in the COVID could be due to drug toxicity related as well. This is an 83-year-old man with elevated liver enzyme and sepsis. Ultrasound was performed for this patient, and we found the cholestatic picture of distended sludge-filled gallbladder. Cholecystostomy tube was inserted, and most of the patient had the tube insertion found that the bile was not infected. This is a case report of a case confirmed the histopathological finding in the COVID-19 patient affected by ischemic gangrenous cholecystitis. 59-year-old male admitted with progressive respiratory symptoms. During the hospital course, patient developed abdominal symptoms and abdominal pain. CT scan was performed and show pictures of cholecystitis with the small perihepatic fluid, which has been increased in the short-term follow-up. Patient underwent cholecystectomy, and in the histopathology, they found there is ischemic gangrenous cholecystitis changes. Now let's move to the pancreas. Acute pancreatitis has been reported in the patient with COVID. As we know, the high expressed of the ACE2 receptor in the pancreatic cells. And 16% of the patient with the severe COVID have elevated serum amylase and lipase, with 7% had significant pancreatic changes on the CT scan. This is an example of 32-year-old woman with severe pancreatitis and hypoxia, and we can see in the axial and coronal CT scan of the abdomen the typical CT manifestation and changes of the pancreatitis with peripancreatic stranding and fluid. And in the visualized lung basis, we can see the typical pneumonic COVID changes. We'll move to the kidneys. Acute kidney injury is a known complication of the COVID infection. However, imaging findings of the COVID have rarely been reported. Bilateral peripheral low perfusion changes, similar findings so in vasculitis are common imaging findings regarding to the kidney damage and involved in the COVID patients. And the proposed mechanism for this, again, could be due to direct cytopathic effect of the virus in the endothelium cell, and that leading to hypotension and hypoperfusion or renal medullary hypoxia. This is a case report for acute reversible renal failure requiring temporary dialysis in a patient with COVID-19 for a 17 years old male with developed severe reversible renal impairment. And we can see bilateral peripheral cortical hypodensities involving the kidney, which completely resolved in the follow-up CT scan. More than this, the COVID can cause not a single organ affected, can affect multi-organ dysfunction syndrome. As this example of a 46 years old woman with diabetes mellitus, initially presented with COVID-19, presented with cough and shortness of breath. Patient condition has been deteriorated, mechanical ventilation and ECMO as well as pressor support were required for this patient. He get more sick and complicated by acute toxic metabolic encephalopathy, pneumonia, acute respiratory distress syndrome, and cardiogenic shock, acute kidney injury, and secondary adrenal insufficiency. And this is the axial and coronal cuts of the CT scan of this patient, and we can see the bowel involvement and as well as the kidney involvement. So this is just a summary for the most proposed mechanism that leading to this GI and liver renal manifestation in COVID-19. Now the question is, as abdominal radiologist, do we have a role in diagnosis and suggested COVID initially in the abdominal imaging? As the all the all things that have been passed through it in the initial in the first of the presentation, actually all these findings we found in the confirmed COVID cases that show the complication of the COVID in the abdominal imaging. But though the abdominal radiologist has a role to suggest an initial diagnose the COVID in the abdominal imaging, this is answered by this paper released in AGR titled by Lung Basis Finding of Coronavirus Disease COVID-19 on Abdominal CT Scan in the patient with predominantly gastro-GI symptoms. As we know, the COVID can present atypically, and some patients presented as GI symptoms solely without any respiratory symptoms. And to be known that CT manifestation can precede the clinical symptoms of the clinical respiratory or respiratory symptoms. So as abdominal radiology should look carefully for the lung basis in case of, especially in this endemic period. This is a case of 26 years old man who presented with abdominal tenderness and GI symptoms. Nothing remarkable in the abdomen. However, the lung basis shows left basilar round airspace and ground glass opacity, and the appearance is highly compatible with atypical infections such as coronavirus, COVID pneumonia. This is another patient, 40 years old man with abdominal and GI symptoms, nothing impressive in the abdomen. However, the lung base show multifocal subpleural ground glass opacities in visualized lung. And this is non-specific finding and may result in atypical infections such as coronavirus. This is the third case, showed of a 50 years old man with epigastric and flank pain and diarrhea. Again, nothing impressed in the abdomen, but the lung bases show bilateral, peripheral, and basilar, predominantly ground glass and nodular opacity. That should suggest for coronavirus disease. So in summary, COVID-19 disease should be approached as multisystemic disease, not just a respiratory disease. GI symptoms and GI imaging findings has been increasingly reported and need specific attention during abdominal imaging assessment. The bowel abnormality, including the ischemia mainly, and cholestasis are common finding on abdominal imaging for COVID patient. The GI manifestation or abdominal manifestation could have caused by different mechanisms, including the direct viral infection with increased affinity to ACE2 receptor and inflammation and that associated with coronavirus infection. The other contributed cause can be due to vasculopathy and thromboembolism and the hypercoagulability status in this infection. The incidence of thromboembolic disease and related complications are reported highly in the COVID patient. Abdominal radiologist must suggest the diagnosis when evaluating the lung bases for typical findings. Recognition of atypical clinical presentation on imaging is necessary to provide timely treatment and prevent spread of the infection. Additional research is needed to further clarify, confirm these findings, and to address the pathophysiology of these changes. Okay, thank you for your attention. Stay safe and stay positive. Welcome for any question.
Thank you, Afnaan. يعطيك العافية. Very nice topic. It's very informative and concise, which also demonstrates the main finding of COVID in abdomen. It's mainly inflammatory process plus vasculopathy, which we see the finding like ischemic bowel and all the other findings. I will allow for one or two questions. Please raise your hand if you're interested in asking or any comment.